Great insights coming from this sitting. And before we went to break, we were talking about the cost of treatment. And with us, I'd like to mention Lynette Imbosa, who is actually a cancer survivor, a breast cancer survivor. We all know we are in that month where we are actually creating breast cancer awareness. If we can get the microphone to her. And she is a Kenyan who lives in South Africa. So a lot of her treatment was actually done in South Africa. And at this point, Lynette, I would like you to tell us, when you think about our healthcare system and how or what kind of services you got in South Africa, what stood out for you?
Thank you very much, Gladys. I think South Africa has its system in place as compared to our system here. Because when I went to the doctor and I was told, okay, this is the situation, I had an opportunity of meeting a group of the medical personnel that were to attend to me. And I was lucky to be in an educational hospital where all the professors, the plastic surgeon, the breast doctors and the nursing, everybody came on board. I was able to meet them. They rolled out the plan for treatment for me. And the medical aid, which we call in medical insurance here, because it's mandatory for every foreign resident there to have a medical aid, was summoned and they actually approved it. And when I started the treatment, from the surgery to the treatment to aftercare, to the radiation and chemotherapy, everything had been rolled out, so it was smooth sailing for me. And even as I went from the weekly doses and the changing of medication, things were smooth. Even for the support group, if you needed one, you just rang the oncology department and they organized for you. They had the ambulance ready to come and pick you if you wanted the ambulance services to take you to the groups in their meeting places for spiritual support or maybe for exercises and other things. And at your workplace also, your colleagues, because some people don't want to stay at home. I was one of those people. I was allowed to work 25%, 50%, 75% as a recovery program for me. So you actually end up feeling human in the midst of familiar faces. You're not isolated to stay on your own and continue suffering. And I think that one helped me in recovery.
All right.
Thank
Now,
you.
she mentions, apart from the insurance cover kicking in, the fact that there was a great support system, and we'll be talking about the role of caregivers in this journey. And George Nyakundi, ICEA, you come in on this one. You launched a cancer cover for 165 shillings per month. Sounds very affordable. What informed that figure?
Thank you, Gladys. We have come from a narrative of hearing from the doctors, from the specialists, that cancer treatment is expensive. Indeed, all of us have been affected in one way or another by this scourge. I call it a scourge because each one of us has been affected in one way or another. Most medical insurance policies do not cover certain expenses that are associated with cancer. For example, Gladys, if one of us was to be taken to India for treatment, and we're required to be accompanied by a spouse or a relative, some of the medical policies, insurance policies that we have, do not cover some of those extra expenses. But also that the insurance policies that we have in this country, in this region actually, have not addressed cancer per se. Most of them have bundled cancer amongst other diseases like hypertension, like diabetes. Now, as a group, the company I work for, ICA Lion Life Assurance, looked at the needs of society, that we are contributing every month towards supporting our families, our friends financially because of cancer. So we set out to design, to architect a cancer product that will come in and support families or clients that are ravaged by cancer. We sought out to make it as cheap as we could. The premium of 165 that we put on the billboards pertains to an 18-year-old girl who has purchased a cancer insurance cover for a sum assured of 1 million. As we age, it becomes slightly expensive. At 40, for example, females tend to pay more than males because, again, as you've heard, at that particular age, we have more females contracting many types of cancers. And for that, they are paying slightly more. This is not a medical product. This is not a medical insurance product. It is a financial expenses product that goes out to support families in case one of them gets cancer. We pay out benefits to the individual or to the spouse when one gets diagnosed with cancer. We also know that treatment of cancer is very expensive. Doctors have spoken about the cost of radiotherapy and chemotherapy. We've come in to support that particular expense by paying out a financial lump sum. But we also know that once you survive a specific period, you may end up going for surgery. This product that we have put up as a company will support those financial expenses that are related to that surgery. Hence, everybody in this country can now afford a product that is standalone on cancer, as opposed to other products that have bundled together cancer together with other diseases.
Okay, which would explain why his billboards are reading the cancer cover. Now, Makomi, I'd like you to speak on behalf of civil society. There has been word, and there's actually a tweet here from Atadan Kyoko, who is asking, why call it cancer cover? Would you put up a HIV cover? What does that say in as far as those who are living with this condition is concerned?
Yeah, thank you very much, and we appreciate the initiative of ICEA Lion to think about cancer. And probably if they had done a lot more stakeholder engagement and involved civil society, for instance, before the product was launched, we would have given them one or two thoughts, and which I will do right now. You know, when you see the billboard, and for many patients I've talked to, when you see the billboard, it gives you the impression that, you know, you see a cancer cover. For them, they don't know medical or financial, the technicalities. For them, they think, for 165, I have cancer, or whatever amount, I have cancer, I can pay and get treatment. That is actually the message that majority of us, even those who would know better, actually have. It took one of our cancer survivors to tell me there's something terribly wrong here because I'm not eligible because I already have cancer, I'm on active treatment, and one of the exclusions is that you should not have had cancer or been on treatment for the past 1 year. I believe that we read correctly. So they said then it is for people who are battling cancer today who cannot afford it. That cover, you know, it's not very helpful. Probably we are looking at a mechanism to enable people access screening and such services, yes. But for patients who have cancer today, who are struggling financially because they want to top up the NHIF since it's not doing 100%, maybe that is what would have been more helpful. The billboards, excellent, but the message sit in many support groups. For the message is all wrong because we are not eligible. So it's not very helpful to us. Okay. So that's how we see it as civil society.
All right, George Nakundi, I'm sure you need to have a sit down with Makomi and other civil society members to have a good engagement and, of course, see how you can improve on that cover. Thank you for making time to speak to us. And we cannot stay away from the conversation of cost, especially when it comes to the cost of the drugs. Because you can go for treatment. If there are no drugs, if you cannot afford them, then it stops there. And this is where we lose a lot of the cancer patients. KEMSA comes squarely in as far as this conversation is concerned. Are we fully equipped as a country to cater for the burden or the demand for cancer drugs?
Sorry. For what we have been given as a package by the government, that is from the Cancer Institute and the National Control Cancer, I would say yes. But as a whole country expectation, no. Because what is happening is that we have in KEMSA around 30 products that are addressing the cancer treatment, and we are basing it on the pack that were given to procure. As I said earlier, we always, you know, go to the demand as expected by the users. So if the user are telling us to buy this, that's exactly what we'll purchase for this country. But before that, we need to have a lot of protocols that are from the guidelines, as was discussed by the clinician or the specialist, that will be addressing that kind of protocol on how to manage these cancers. We know we have the first line cancer treatments, we have the second line, we have the third line, and we also have other products that are really coming to support the cancer patient. I like the idea of how it has been said from South Africa. We need to use a multidisciplinary approach
to this. Before we get to that, Dr. Manjari, I'd like you to speak on the fact that cancer survivors and even specialists in the room have said when the drugs are released by KEMSA, they seem to be on a certain cost, very affordable. But by the time they're being distributed to the different treatment center and pharmaceuticals, the price hikes. Are you in position to actually cap this and make it more affordable to Kenya? To Kenyans?
Yeah. Well, as I said, as we purchase on bulk, we pass that benefit to the users, those are the patients. What needs to be done is a proper post-distribution survey so that we know the products as it left KEMSA, at this markup, it is still the same product that will be used all the way down, and no other extra cost should be pushed to the patient. Because we have received around 40 million now from the government to buy the starter packs. And those we have taken to all the 10 centers in this country, that is Meru, Nakuru, Mombasa, and all these Rogisa in Bomet. We actually took a very successful program there. And these products should not then be loaded with huge markups to the patient. And that's the conversation that needs to be done. We need a price control mechanism in this country. We need a way of how do we track the load to the patient as the products are taken down all the way to the mouth of the patient. Because KEMSA products and the prices are in the website. You can look at the products and you'll see how much it will cost Herceptin when it's taken down to the patient. You can see any other product that is in our LMIS, that is the Logistic Management Information System, where all the ordering products you want to order in this country they are there, and you can pick the products that you have. For us, we work on a revolving fund where we replenish as the products are taken down, and we'll replenish as much as it is expected, because we have framework contracts with our suppliers, and we can only guarantee them business if the products are going to the patients that were intended to.
Okay, now I'll bring in the private sector. If we can get to the microphone to David Odada, who is an oncology nurse at the Aga Khan Hospital. There is talk that getting treatment from a private facility is very expensive, hence the lines that KNH has to deal with, or any other public facility. How do you deal with patients that come to you, they have the need, but they cannot afford it?
It's not necessarily true, because what happens, especially in the facility that I work, we have a multidisciplinary tumor boards, whereby cases are discussed and prognostics are also determined. And you'll find that there's a huge number of patients who the hospital covers in terms of our welfare system. So there are those who would afford, and I wouldn't say it's cheap in a way, but it is accessible to the population that basically comes to our hospital. Not forgetting that the welfare system is there to be able to cover for those whose prognosis is good, and everything is covered.
Okay, now at this point, I would like us to talk about palliative care. We've touched on it, but we know how important it is for those that are actually dealing with cancer, that they get that very important support system. On the set, we have Mary Moshemi from Trinity Healthcare. If you can get the microphone to her, and she can probably articulate how important palliative care is and how accessible it is to cancer patients. If you can stand up.
Thank you very much. Palliative care is very important, from the diagnosis, treatment, as well as investigations. We normally do it to relieve the patient pain, as well as give the psychological counseling, and as well as doing the rehabilitative therapy. So it's normally not very easy. It's not very accessible, especially we give to a call to the NHIF to give a package, to implement a package for the palliative care so that the relatives do not get a lot of burden in terms of finances. So what I can say, palliative is very important, and it is start from diagnosis. And it is not only for cancer patient, it's also for all other life limiting illnesses, including the stroke, the diabetic patient, you know, all those kind of patients, the hypoxia patient, they all require palliative care. But in this case, for cancer patients, very important. We find some patients, they really require a lot of counseling. They go and find that there are a lot of myths about the cancers, and some of them even commit suicide. So it is very important. The cost is high, and we advocate for NHIF to intervene.
Okay, if you can get the microphone to Grace Gashanja from Chiromo Lane Medical Center. She is the resident psychologist. Now, she has touched on the fact that it's important to actually have palliative care, but also the psychosocial support for the patient and the caregivers. If you can stand, kindly touch shortly on the importance of the same.
When we talk about cancer care or care of the terminally ill, one of the things that comes in and one of the things that we mainly focus on is that it affects the mental health of these patients and also of the caregivers, because one of the things that this person starts dealing with is grief. So we have grief of just the patient just not only losing their functional on a day-to-day basis, but also their caregivers fearing death, because there's a common connotation that this person is about to die and the cost that it brings in about. So one of the things that we look at is that the support of it, and this person being able to be there, the support, not just psychologically, but also just presence. Looking at ensuring that the caregivers and the patient themselves are getting enough sleep, eating well, maintaining their level of functioning on a day-to-day basis. That in itself just ensures that their mental wellness is taken care of, even as they're continuing with care and treatment at the hospital.
Okay, now I will have to stop you there. Definitely many angles to this conversation that need to be heard, but we don't have so much time to do so. But we shall be putting together another discussion to at least address much more of this, and definitely all the stakeholders at this point would have had a more concise meeting and sit down to see how best to serve those that are living this reality, caregivers and survivors, and of course the stakeholders. At least you've heard from each other and where the gaps are in the system. It has been #Cancer Dialogue, a Health Diary special edition. My name is Gladys Gashanja, and we have been coming to you from the Westwood Hotel here in Nairobi. Until next time, have a good evening.